down, stereotactic radiotherapy, maybe 10 years down the line we say RCC is not meant for radiation, and definitely irreversible electroporation. If we go with guidelines, if we go what we understand that this is mainly meant for fragile patients, the patient which we cannot operate. I think European guidelines are with us. But yes, if we see AUA and NCN, they say that this option is now a standard alternate option. Probably we should keep it as an option, alternate option, apart from NSS for these T1A lesions, and wherever feasible, if patient is fragile in T1B2. So these are the patient selection. We will understand that any patient, old age, fragile, poor performance status, numerous comorbidities, compromised renal function, high-risk morbidities, and T1A, definitely we can have this, because when we need to discuss with patients, it is a shared informed decision making. So we cannot hide the other options also as a uro-oncologist, that we don't give them option, that what other options are available. Regarding the approach, whether it is percutaneous, laparoscopy, open or extracorporeal, there is all the studies they show similar overall survival and cancer-free survival. But yes, if we talk about AUA guidelines, they have supported percutaneous over other approaches because of less morbidity and cost. Renal mass biopsy, yes, pre-procedure indicated in the guidelines, post-procedure still debatable whether it is necessary or not, as we all understand that 20% patients still can have benign lesions. Let us come to one by one. The most definitive is like, we have cryoablation. It is how it works, as the word suggests, it is, create intense cooling. So the tip of cryoprobe, argon gas is depressurized to have intense cooling. We need to have 2 freeze throw cycle, rapid freeze, slow thawing probably is the type what it works. Several probes need to be placed in the tumor to map it properly so that the area should be covered. And definitely it is how it is work and require a supporting department help. It is not the uro-oncologist who will go and do it. He can definitely be a part of the team, but yes, you need a supportive department. Similarly, for radiofrequency ablation, RFA, definitely there are, it is through electric current into a tumor. The ions, they agitate, cause heat, and then it goes till 69 degrees centigrade and denaturation of protein. And again, placing so many of probes, and the assessment is done by doing imaging. Microwave ablation refers to use of electromagnetic microwave. Vigorous movement of water molecules in the tissue causes increase in temperature. It is again based on heat based, and that is why the mechanism is different. That's why we say it can overcome the heat sink effect. We talk about HIFU, high intensity focus ultrasound. It is again a form of a thermal ablation. Ultrasound energy is focused on a small volume of tumor, causing movement and friction of cells. And yes, most important advantage is extracorporeal way of giving it. You don't need percutaneous, lap or open. You can use extracorporeal, but there are so many limitations as of now in literature about HIFU. It is not ready for clinical use as of now, because when the literature assesses the tissue damage, it is only 15-30% of tissue which was targeted, and the damaged tissue found only 15-30%, so the rest is left over, probably may have recurrence. Stereotactic radiotherapy, I think our colleagues will be presenting in the next talk. I will skip it for a while. We have a separate talk on this. Irreversible electroporation, it is disrupting the integrity of cell membrane through the formation of irreversible nanopores and causes cell death by inflammatory reaction. The mechanism is again on high voltage, and most important thing, probably it is evolving, it is a non-thermal ablation. This feature allows the ablation of tumors that are in close proximity to potential heat sink and vital structures where we call blood or urine, hilar tumors. So again, the most important criteria falls there. When we do a procedure, as a uro-oncologist, we also need to monitor it, whether we are really doing it appropriately, apt. So I think CRA, cryoablation, is one of the techniques where we can monitor what we are doing. But rest of the procedures like RF and microwave, they cannot be monitored because they work on principle of heat. It is developing a thermal lesion. So this is a limitation of these procedures. If we talk about assessment, the RECIST criteria doesn't fall here. It is mainly when you do an imaging, you stop seeing those enhancing masses, you see the shrinkage of tumors. The probably absence of contrast media is the way you assess all these modalities of ablation. We here today, probably we need to take some message. By the end of this presentation, when we stop the presentation, we should be aware that If we talk about procedure timing, what we need to select among these? If you are worried about bleeding in these frail patients, uncorrected coagulopathy, what to select? If you are talking about the size of tumor, if it is more than 4 centimeter, if it is more than 3 centimeter, what to select? And definitely hilar tumors, what to select. So I think these answers are still unanswered in our presentation. My colleague Vikas will take over from here, and probably he will be discussing about the safety, efficacy, and effectiveness, and we'll try to give this answer in a short while.
Thank you, sir. So the clinical outcomes of ablative techniques invariably correlates with the size of the kidney tumor rather than the technique employed. However, there are subtle differences in between these ablative techniques which can help us in choosing a single modality over the other. So RFA is a heat-based technique which is associated with shorter procedural time and lower bleeding risk because heat has got an inherent coagulant effect. It is also associated with heat sink phenomena, wherein the generated heat tends to decrease in the region where there is continuous liquid flow. So thereby making this modality a less suitable one when the lesion is located in the hilar or central perihilar region. Also, the increased impedance from generated heat tends to decrease the success rate when the diameter of the lesion increases to more than 3 centimeter in size. Cryoablation, on the other hand, is a cold-based technique with the advantage, as told before, advantage of real-time visualization of the ablation zone. It is less painful and can be used to ablate a much larger lesion as compared to RFA. However, it is associated with longer procedural time and it has high bleeding risk. Microwave ablation is another form of heat-based therapy with the shortest procedural time. However, microwave ablation reaches temperature which are much higher as compared to other heat-based technique. So this property is advantageous in one sense that a much larger lesion can be ablated within a short period of time, and on the other hand makes this modality a dangerous one when it is used for a centrally located hilar or perihilar tumor because the thermal damage can cause calyceal system as well as ureteric strictures. So unfortunately for radiofrequency ablation, no RCTs have been done till date. Whatever data we have is from retrospective observational studies, and these studies have consistently shown that the recurrence-free survival for 5 years and 10 years reaches 96 and 93%. Even in salvage setting, RFA reaches a success rate of 83% at follow-up of 4 years. However, when the tumor size increases, the disease-free survival drops down to 74% as compared to 90%. So this was a systematic review and meta-analysis published in 2022. It studied the long-term outcomes of RFA versus partial nephrectomy for clinical T1 tumors. It included 7 studies with 1,635 patients with at least 5 years of follow-up. So they found out that there was no significant difference between RFA and partial nephrectomy in terms of cancer recurrence, progression-free survival, cancer-specific survival, and major complications. This was another paper which was published this year only, which studied the perioperative and oncological outcomes of RFA versus partial nephrectomy for clinical T1A tumors. So the oncological outcomes were similar across the two groups. However, RFA was associated with significantly shorter procedural length, hospital stay, blood loss, and need for analgesia as compared to partial nephrectomy. So this paper by Waugh et al. Was one of the largest series published which studied the outcome of RFA in 200 renal tumors. They found out that the complication range from 9 to 27%, and the major complication includes ureteric stricture, acute tubular necrosis, calyceal cutaneous fistulas, renal abscesses. And most of these complications occurred when RFA was used for a hilar tumor. The minor complication includes the cell-limiting subcapsular hematoma. Moving on to the cryoablation outcomes, for cryoablation also we don't have any RCT. The data from observational studies have shown that the recurrence-free survival and the cancer-specific survival varies between 95 to 100%, and most of the recurrence occurs within the first 2 years of follow-up, and the metastatic progression range from 1 to 4%. So this was a systematic review and meta-analysis published this year, which studied the clinical and oncological outcomes following cryoablation versus partial nephrectomy for clinical T1 renal tumors. So it included 14 studies with 6,487 patients. So they showed that the rate of complication was significantly lower in patients who underwent percutaneous cryoablation as compared to partial nephrectomy. And in terms of oncological outcomes, there was no significant difference in local recurrence-free survival, metastasis-free survival, and cancer-specific survival when only clinical T1A tumors were analyzed. However, the overall survival tilted highly in favor of partial nephrectomy. And this can be explained because most of the patient who underwent cryoablation must be having much higher comorbidities and poor performing risk. This was another systematic review and meta-analysis which compared RFA versus cryoablation for T1 renal tumors. It included 10 studies with 2,367 patients. They found that there was no significant difference in terms of complication, technical efficacy rate, change in serum creatinine level, and 5-year survival rate. However, the local recurrence rate favored cryoablation over RFA. But when the subgroup analysis was done, it was found when only clinical T1A tumors are analyzed, there is no significant difference. It is only when the clinical T1B tumors were included in the analysis, the recurrence-free rate favored cryoablation over RFA. This was another paper which studied the complication following 573 percutaneous RFA and cryoablation. So they found that there was negligible difference in terms of oncological outcomes. The complication rate ranged from 3.5 to 5%. With cryoablation, the specific complications were bleeding and hematuria, and for radiofrequency ablation, nerve injury and urothelial injury were the most common. Particularly the genitofemoral nerve and the femoral cutaneous nerve were involved in the nerve injury because of the heating of the iliopsoas muscle. For microwave ablation, the studies have shown that the recurrence-free survival reaches 93.3%, and in a retrospective propensity matched analysis between microwave ablation and partial nephrectomy, no significant difference was found in local tumor progression, cancer-specific survival, and metastasis rate. This is the only RCT which has been published for ablative techniques which compared microwave ablation versus partial nephrectomy. They found that there was no difference in the recurrence-free survival, hospitalization time, or change in estimated GFR between these two modalities. However, microwave ablation was associated with significantly less blood loss, complication rate, and decline in postoperative renal function. If we see the cost comparison, the nephron sparing surgery may anywhere cost 2.5 to 5 lakhs depending upon the city to city. The cryoablation cost in our country range from 1 to 2 lakhs, and similarly for RFA also, the treatment cost is around 1 to 2 lakh. So now can we have the answer for the question raised earlier?
Yeah, I think we left the house with these questions. So probably the answer probably is this, these options are definitely there based both on evidence as well as practice. We don't have these resources, that is the other issue. We don't have expertise, that is the other concern. We need to refer. If we talk about procedure time, so definitely microwave has the shortest, and then RF, and then cryo. If we talk about bleeding, RF has an edge over cryo. If we talk about larger lesions, more than 4 centimeter, cryo has an edge over RF. If we talk about hilar lesions, cryo and definitely have an edge over RF and microwave due to heat sink. So I think keeping this in mind, if we know this indication, at least the referral will be important, and we can refer a patient and take a consultation with our supporting team, and maybe a informed shared decision can be made with the patient of these SRM patients. Thank you so much.
I have in fact, sorry, okay. Regarding RF, we had 2 cases experience, that's all, nothing more than that. But both the cases, we were not confident in doing blindly on a CT guidance. So what we did is we did a diagnostic laparoscopy, mobilized the fat there, and under vision, we passed that needle and monitored by a ultrasound from there. So the ultrasound should create a vacuolation, that bubbles should come all around. Where is the maximum site of the spread is there, that will be bubbling. So that will show you whether you are inside the tumor or completely it is taken care of or not. I think that was...
In fact, there are...
No, that's exactly. We had this, both the patients had solitary kidney and 4 tumors. 3 in 1 and 4 in 1. So in which case what we did was, when one patient, in fact I think I presented in Tata one day, we did a enucleation of both the tumors above, and we did an RF of the mid-polar tumor. So that same patient underwent a radical nephrectomy on the other side. The second patient was a solitary kidney with another 2 or 3 tumors, wherein we did a RF independently.
These were inoperable tumors, sir, because
It's not the question. We were not confident to do. So it's nothing like inoperable. It can be, but the only thing is all were solitary kidneys, so we were not really confident.
have you seen more than the T stage, Have you seen the histology of these tumors? How the response is? Because SBRT was showing that clear cell RCC has got some role. Likewise, have they seen, other than the size of the tumor, the histology of the tumor response to the
No,
thermoablative?
the treatment outcome doesn't depend on the histology because it is just heat-based or cold-based technology that destroys the cell in the particular region. So whatever studies I have quoted and we have gone across, there is no correlation with the histological type.
And moreover, the follow-up we have clearly, what evidence we have shared is that follow-up is there is debatable concern about the biopsy post-procedure to say whether there is something left behind or not. So probably the follow-up is primarily based on the imaging and seeing the non-enhancement as the criteria and the shrinkage of the tumor in due course of time. And regarding the approach, what Malik sir was asking, probably sir, any approach is definitely if you use percutaneous open lab, it depends upon whether that area is properly covered that by the probe or not.
First thing.
And RF per se, it's not very difficult to monitor the thing what we are doing. We can just place the probe. Cryo is best monitored by seeing it. RF is difficult to monitor.
RF is, you need an ultrasound to show the vacuolation coming on the periphery of the rim of the thing. You see the thing, fan opens up and it gives you a particular shape, around 2 centimeters is the diameter if I remember correctly, which gives, and that globe of the thing will become ablated. And in the periphery you'll see that vacuolation with hyperechoic shadow coming up on an ultrasound. But the problem here is we need to be sure that we may need to attempt once more after 3 months if there is an enhancement happening on the CT scan. So 3 months to 4 months is the time when you do a CT scan. If there is an enhancement, we may need to repeat it.
People have started doing CT scan immediately after the ablation procedure so that if it is needed, it can be done in the same setting.
Immediately after ablation is not a great idea. There is one paper by I think Marburger, I'm not sure, where they did RF for about certain cases and then the partial nephrectomy later. All the 2 cases had a viable tumor inside. So RF, talking about RF as a sole modality without follow-up is probably will not be right.
Thank you very much, all my chairpersons and the speakers. Now I would like to invite my new team of chairpersons, Dr. Shivaji Basu, Dr. Premnath Dogra, Dr. Rishi Nair, Dr. Nirmal TJ, Dr. Sambit Mohanty, and Dr. Vidur Bhalla. The next topic would be now SBRT in small renal masses, which would be presented by Dr. Ankit Mishra and myself.
So a very good evening to the chairpersons, faculties and delegates. I am Dr. Ankit and along with Dr. Anuj here, I will be talking about SBRT in small renal masses. So what is the common thing between these 3 pictures? One is the saber of Tipu Sultan, the other is the saber shot of Roger Federer, and the other is the saber which is an equipment in the radiation oncologist's purview. So it stands for stereotactic ablative radiotherapy. Upfront disclosure, we are both urologists by training, so pardon and apologies for our limited knowledge of radiation technology, but we'll try to understand this technique from the urologist's point of view. As we all know, renal cell carcinoma is not uncommon with an incidence of 0.33 million per year, and the incidence that has been continuously been on the increasing trend. In the last decade, it has increased at 0.7% per year. The reason being increase in the life expectancy, greater use of imaging studies, more accessibility to clinics and insurance schemes. The median age of this cancer is 65 years. The greatest increase has been seen in patients older than 70, and many of them have their other comorbidities. So SBRT or SABR, SABR, it stands for stereotactic body radiation therapy. It delivers a very high focused radiation dose for a very short period of time to a particular organ, and this condenses the total radiation course. Only 1 to 5 visits would be required instead of multiple weeks. It is non-invasive and it can act as an alternative option for therapy. What all the tools that are required for this therapy? First is the conviction and the convincing ability. The other would be a linear accelerator with image-guided radiation therapy, which can give a dosage of 40 to 50 grays in 3 to 5 fractions, and physics support. The questions that we would be looking forward to answer today from the point of view of radiation oncologist would be, what is the local control of this therapy? Is it really safe? Can we pull it off with a standard linear accelerator? What is the best fractionation? What are the issues to deal with, like motion management, planning and contouring? From the uro-oncologist point of view, these would be the patient is not opting for surgery, so why not offer an RFA or a thermal ablation? Can we really do an SBRT in a single kidney? And even if the tumor is more than 4 centimeter, how do we follow these patients up? What happens to the GFR in the long run? And do we biopsy to prove the local control? Now, conventionally, RT doesn't work in RCC. So why we say this is that previous studies in the 1970 eras, comparing the pre-op radiation and post-op radiation, they showed that it was not very improving in the overall survival. In fact, it proved to be detrimental also in some cases. But the problem with these studies were they studied the conventional fractionated doses, which were 30 gray given over 15 fractions. The other obvious problem was that the exposure of the other body parts to the radiation, and so the radiation in this early era was associated with high rates of complication. However, there was a meta-analysis which was done, which showed that post-operative radiation therapy definitely reduces the loco-regional recurrence with acceptable GI toxicity if modern techniques like 3D imaging, conformational radiation therapy, and IMRT are included together, even in patients with high risk. So there is a need to run a multi-institutional trial to see the additional benefit and just not remove the RT from the options. The other studies are there which show that the human tumors which are radio responsive, they have a direct correlation with the slope of cell survival curve. And there are certain cell lines like CAK1, CAKI1 and A498, which have been showed to exponential decrease in growth when they were exposed to higher grays per fraction. That was a cutoff of 6 gray. So how does stereoablation overcomes the radio resistance? In this pathway, we see that the conventional fractionated doses, which were around 1.8 to 3 gray per fraction, they usually act on the tumor cells and create a hypoxic environment, which leads to activation of HIF1 alpha and promotes the VEGF factors, which maintain the endothelial lining and are responsible for the radio resistance. However, a single dose radiation, more than 6 gray per fraction, it causes a direct damage to the tumor cell as well as the endothelial lining by converting the sphingomyelin to ceramide, which causes endothelial apoptosis, and this is responsible for the radio responsiveness when a high dose of radiation is given to kidney. So again, this shows the same thing, the same pathway, and when we give a single dose radiation of more than 8 gray, there is endothelial apoptosis and tumor response is there. So in a way, we can compare the conventional radiation with just raindrops falling from the sky and ablative radiation as just a flood for a short period of time. So summarizing the switch, why moving towards a stereotactive radiation therapy is because of the improved diagnostic imaging, thin slices of CT scans being available, patient immobilization techniques like backlog and body bag, and newer techniques of IGRT, IMRT, image guidance, motion management, along with this leverage of biology of this pathway of conversion of sphingomyelin to ceramide, endothelial apoptosis, resistance to hypoxia, and the abscopal effect of immune response, which causes anti-tumor effects in these patients. So this all challenge the conventional wisdom that RT does not work in RCC. So I would invite Dr. Anuj to take the discussion further.
Thank you, Dr. Ankit. So with the concept in mind that the previously understood concept about radiotherapy, that it is not, it's a radio-resistant tumor, has now been changed by giving more dosage in lesser fractionation. We come back to this concept of what is the role of radiotherapy in small renal masses. So the previous, we only have some very restricted data that we are dealing with, but the best meta-analysis that we have in our hand is of the 2016 IROC analysis. So this was majorly done by Peter McCallum, Karolinska, and it was a consensus statement from the International Radiosurgical Oncology Consortium for kidney for primary renal cell carcinoma. So this is an exhaustive summary which we are dealing with, and as we had seen for the various ablative therapies, we still have the same criteria of patient selection. So the consensus statement covered the various aspects, including treatment technique, the patient follow-up, medically inoperable and patients who are at risk of dialysis or patients who are not willing for surgery are the prime candidates that we should think about for giving this option. Both small and large tumors. This is an important differentiation that is there compared to what other thermoablative techniques we have, that even now there is an emerging data that we can use these SABR techniques for larger tumors too. Along with that, the follow-up should be there. So the follow-up in this is keeping in mind the concept that the tumor is having a very longer course in terms of its resolution. So this is just to give you an idea about how it is planned. So this is a very technical aspect compared to what we should be understanding as urologists. So as we can see, the innermost is the red zone or the target zone. And subsequently in concentric circles, we go along. And this is the area that we target for our radiotherapy. So this is how it looks. The treatment is in the neon blue area. This is where the radiation is going from all the directions. And then we have a very steep dose gradient, and immediately adjacent organs are untouched. So these all things are there. So we go back to that IMROC analysis, what kind of patients we were dealing with. So the median age was 73.6, and medically inoperable were most of these patients. So 96 patients, which was almost 75%. All these patients, most of these patients had a biopsy which was done, so which is also recommended in this study. The maximum dimension, as we can see, 4.2. So it was covering both the small renal masses as well as the larger ones. And many of the patients, so almost 1/3 of the patients were having a solitary kidney. With a BED 10, a median of 87.5 gray. Now this is very characteristic. So this is what is called as a biological equivalent dose. So the amount of grays or the amount of radiation that you are giving in 20 fractions, you cannot compare the same amount of gray which you are giving in hypofraction. So the BED is the most important thing, and subsequently we'll also know that this is one kind of a limitation in this study. So the BED ideally in these cases should be more than 100 grays. So this was the follow-up that we all saw, that it was 92% of cancer-specific survival was there at 5 years. The local failure was almost 5.5%, and the distant failure was around 10.8%. So this was a follow-up of almost 190 patients on a 5-year. Again, if we go into the sub-analysis, so in solitary kidneys, how does it perform? So when the median tumor diameter was of 3.7 centimeters, with a mostly more than 4 centimeters were approximately 37%, the mean eGFR decrease, which is of the prime importance, was around 5.8 plus minus 10.8 ml per minute in solitary kidneys. And the dose of the fractionation was 25 grays. So in solitary kidneys also, these patients, there was a decrease in GFR, but not all these patients landed up into dialysis. As was also covered in the previous studies, the various RFA, the cryoablation, and the microwave ablation, as shown by Dr. Ankur, that the wheel which was there, the taraju which was there. So if we put an SABR with all these techniques, we would say that it won't require any general anesthesia as it is required in the surgery. It is very much important that it is also good for the perihilar tumors. Large tumors, there is a restricted data, but even in large tumors, we can use the stereotactic ablation techniques, and also in the non-invasive ones. So this is how, again, we can see that in concentric neon area, this is the one which is being targeted in the IGRT technique, and subsequent follow-ups, we have an important response rate. So as it is shown, it is slow but a continuous response. So a slight informal thing, once I was given this topic of SABR, I searched it on the net. So the first thing which came was an Arabic word, sabr. So I think the follow-up needs some sabr or some kind of a patience, because these patients, they take a longer response rate compared to what we see as surgeons in terms of our partial nephrectomies. So as we see that the response rate comes till 3 years. So many patients who might not be showing a good response rate might have to actually be seen after 3 or the 5 years. Also, if we see in terms of the GFR, the actual or the mean decline was around 13.5. So an ideal kind of a recommendation is that we should have a good GFR of these patients, approximately 60 ml per minute, so that we can use these techniques. So what is the right patient that can fit in? We don't have a very definitive guideline. There are no EAU or NCCN guidelines which strongly recommend this therapy. But yeah, we can see such patients in our OPD and decide if we can give a shot of radiotherapy. So these can be medically inoperable, early stage primary RCC, patients who are not opting for surgery. These are too big, unsuitable for RFA or NSS. Any patients with single kidney, incidentally detected as synchronous or metachronous cancers, and with the philosophy of an abscopal effect that by giving radiation we can also tackle some other kind of malignancy which is there, we can use this technique. So in terms of the tips, and this is a little technical aspect, we need to see a GFR and biopsy before the surgery. The important point is that in these cases, the respiration rate might alter the tumor target. So we have to see in terms of what kind of slice thickness we need. We need a FFF, which is a free flat filtration. So whenever we are doing a 4D CT in these patients, we target the tumor, and with respiration, we try to achieve the same response. So tumor visualization with high precision planning and delivery, a robust image guidance with a quick delivery, and intrafraction motion management is needed in these cases. Cybernet system for SBRT is the one which helps us in, improving these outcomes of respiration that we can do. Another very important concern is that kidney is deep down inside the abdomen, so there can be a local toxicity. But with these latest techniques and PRV, we can improve our target and do lesser damage to the surrounding organs. So again, this data of the IMROC, it showed that by giving hypofractions and a more dosage would be little more better than the hyperfractionation. So in the coming times, we are kind of combining these studies with immune checkpoint inhibitors, and these results of Samurai, Cytoshrink, and Radster are still pending. So the take-home message is that SBRT to primary RCC is a real option in clinical practice. With the coming Australian guidelines and subsequently, this will be a viable option in present future. Post-SBRT responses are slow and steady, and hence a sabr. And post-SBRT GFR drop is 10 to 15 ml minutes over long term. So this is our Uro-Oncology division of surgical radiation and medical onco at TMH. And I would just use a small short opportunity of inviting you everyone at our Homi Baba Cancer Conclave. This is our first conference that we are holding in this August. Thank you so much.
Well, thank you, Dr. Anuj and Dr. Gagan. For a short while, I think we have to go to OT, Dr. Pranjal Modi. He is waiting, I think, important steps. Can we connect us to the OT, please?
Francis, sir?
Yes.
Your mic answer.
Yeah, so just we are going to apply the bulldog.